first installment of our National Health Insurance in 30 series by Rural Support Network. So today, super exciting. We have a brief overview on the NHI, and that would be like the what and the why of NHI, and we'll have questions and answers at the end. So today's speaker is Professor Leslie London. He is a public health specialist with an interest in human rights, public health ethics, farm worker health, prevention of alcohol-related harms, and the health hazards of pesticides. Most of you will know him as the head of the Division of Public Health Medicine at UCT. He leads the Health and Human Rights Program and is an active researcher in the Center for Occupational and Environmental Health Research. He is also a very active member in the People's Health Movement and has been part of policy advocacy around universal health coverage and community participation in health. So without further ado, Prof. London, it's all yours.
So as Priyanka said, I'm active in People's Health Movement, and I'll end with a little bit of information about that. But I want to thank Di McIntyre, who was head of the Health Economics Unit, who's done a lot of work on NHI. She's now retired, but just to thank her and others for some of the contributions here. So where does the NHI come from? And this is from the Department of Health. Quite clearly, they locate the NHI as something that is about health as a right. So the previous Minister of Health is often quoted. This is a quote of their website. The right to health should not depend on how rich we are or where we happen to live. Large numbers of our people continue to die prematurely and to suffer unnecessarily from poor health, in spite of the fact that government has tried since 1994 to ensure that everyone in this country has equitable access to the necessary healthcare services. There are still serious challenges. So that's really where the NHI is located in the politics of health in South Africa. But as you know, we can't separate it from wider society. We are the most unequal country in the world. We used to be the second most unequal after Brazil. We are now #1. So more than 50% of the wealth of the country is owned by the richest 10% of the people, and the poorest 10% own only 0.2% of wealth in this country. So we are the most unequal country in the world, and that's a big challenge for an NHI to address. It affects healthcare services, and I don't know if anybody wants to look at these graphs and see what's going on here. So you have public set of bar graphs on the left, public sector utilization by income. So on the left-hand side, the orange are the poorest, and the sort of dark slate, gray, blue are the richest. You can see a gradient there. It's actually going up in the public sector. In the private sector, it goes up very steeply. So if you're in the richest 20%, so if you sitting in the right-hand column, you have about twice as much, more than twice as much utilization as the next quintile. And so overall, there's a very steep gradient. But what's shocking about this is even public sector services, if you're wealthier, you get more out of it than if you're poor. So we have a very unequal health system as well. And this is just a different way of presenting what I showed in the previous slide. Di McIntyre and John Atiguba showed this, that the percentage of benefit is shown in the stacked bar graph, bar columns on the left, and on the right is the percentage share of need based upon income. And you can see those who have relatively low need are making quite substantial use of healthcare, whereas those who have high need are making relatively low use. So that's the so-called inverse care law, and it applies very clearly in South Africa. So that's what we're trying to address with this NHI. But the NHI has a very, very long history. It might surprise you, but it's actually almost 100 years old. So in 1928, there was a commission on old age pensions and national insurance. And you can see over the years, and particularly just before the Second World War, there was a lot of interest in what was called the National Health Services Commission, the Gluckman Commission, which is sort of famous internationally because it was the first thinking around community-based care, community-oriented primary care. But of course, during apartheid, that was all extinguished, and you'll see the next discussion is actually in 1994. So during the period of apartheid, there was no real grappling with questions of equity in healthcare, because basically those in power had sequestered the state apparatus to serve their own benefits, and there was no need to think about equity or no pressure. And it only since 1994 this has been on the agenda. And you can see a series of structures, meetings, policies looking at it. But it was really in 2007 when the ANC Policy Conference adopted the NHI as formal policy that had led to the current developments in a more coherent way. So there was initially a party political process within the ANC, and then it became a ministerial sort of government process, and experts were appointed in 2009. Professor McIntyre was one of those experts. But it took a long time incubating that, and the white papers finally appeared in 2015. The bill in 2017, the final bill in 2019, and now we're waiting for the act. So that's where we are at the moment. Here's a sort of timeline, and it just shows you that in the scale of things, the bill is quite late in that whole process. And I'll come back to this. This is where we're at the moment. So just to understand how money is spent on health in general. So you can have sources of money that locate in individuals in the household, and you can have sources of money that are because you're employed. So they're located within businesses or companies. And you can get healthcare in various settings. So people can pay out of pocket, which means you go to the chemist, you buy something, or you go to the GP and you pay for something, or you go to a hospital and you pay out of pocket for your healthcare. On the other hand, most people who can afford it will adopt insurance, and then those who don't will have government tax pay for them. So if you adopt insurance, you pay into an insurance scheme, a medical scheme so-called, and usually if you're employed, your company will pay some part of it and you will pay another part of it, and that will purchase for you healthcare when you go to a facility. Sometimes you have to pay a co-payment, but essentially it's covering the costs of healthcare. On the other hand, if you're dependent on government tax, public sector services, you don't really pay, you only pay through your taxes to government, and government provides the service. The problem is that we have a very unequal society, as I showed you, and about the people make use of private providers and public providers, and the private insurance mechanism really enables a small proportion of the population, roughly 16%. It's kind of varied between 15 and 20, but it's probably going down now, who spend about 44% of all health spending on the private sector, in the private sector, through insurance mechanisms. On the other hand, government tax, which people who are poor will contribute, but also richer households, represents about 43% of spending on health, and government pays our salaries as public providers. So you can understand that a very large proportion of the population are dependent on government services provided through the public sector. Small proportion of the population, 16%, spend almost the same as what government spends on the 84% to use private providers. And there is some direct use if you have some disposable income to purchase services directly from a private provider. So how will the NHI change this whole setup? So if you consider you have rich households, you have less rich households, and you have companies, and you have providers on the other side, well, the NHI fund will be created, and all the money will go into the NHI fund. And that will purchase services from whichever providers are available, whether they're public or private. You can have private insurance, but it will only provide services that are not provided by the NHI fund. So it will be outside of the NHI, and it will be prescribed, it will be limited to certain kinds of services. And the NHI fund will remove that co-payment. So at the point of contact, you don't have to pay anything yourself. That is a big problem currently in the insurance sector. And over time, the idea is the NHI fund will grow and eventually extinguish private insurance or reduce it to something that is only really for very select services, because basically, even if you're rich and you get a good service out of the NHI, why would you pay extra to pay into a private insurance if you're going to get your core healthcare through an NHI fund? That's the logic of the NHI. So the intent of the NHI is to provide universal coverage, financial protection, And what we mean by that is when you get sick, you are not prevented from getting care if you don't have the money to pay, as is the case quite often now. It's supposed to address the inequities of the past and ensure that there's a unified healthcare system. And by unified, it means that there's a single payer system, meaning there's only one body that will pay for healthcare, the NHI fund. In the US, for instance, you might know there's multiple payers. It's called the healthcare market or healthcare exchange or something. But basically, it's about competition, and competition is supposed to be good. But there are also other downsides to that. The logic of it is that if you have a monopsony, in other words, not a monopoly, but a monopsony where you're purchasing services and you're the only person who purchases, you can keep the prices down. A single payer is the core of that. And it gives you risk protection, meaning your likelihood that you'll need health care from catastrophic health-related expenditures, and improves health outcomes of the population. And it addresses challenges in both public and private. So risk sharing means that those who are healthy and have a low risk will end up paying in more than they use from the fund. So you pay in a certain amount, everyone pays the same proportional to their age or risk. But if you're healthy, you will end up using less. So you're paying more and you cross-subsidize those who are sick. And that's the logic of a national health insurance. Current, or in fact previous systems, when insurance was run, it allowed insurance companies to risk rate. So if you were low risk, you paid less and you joined, but it meant that the people who were sicker didn't get any subsidy. So there was no cross subsidy, and that defeats the purpose of insurance. South Africa has remarkably the biggest proportion of healthcare delivered through private sector, even bigger than the US, which is the home of capitalism. But the US has actually quite large publicly funded services, the Veterans Administration, for example, and others. So, in fact, South Africa and Namibia have concentrated private healthcare through insurance much more than anyone else in the world. And so our current system, which I mentioned at 44%, you can see tax is 43% of funding in healthcare, covers 84% of the population. Medical schemes, of which some are big and some are small, and there's a whole lot of them. They receive about 44% of all health expenditure, but they cover only 16% of the population. And then there's that out-of-pocket pool of about 13%, which both sectors will purchase, mainly through private GPs and pharmacies. So that's what our current health system looks like. The idea is that in a universal health system, the out-of-pocket payment starts to shrink. So in the NHI, there will be no fees at the point of service. The public funds will grow because it'll be tax plus all the money that would have been funneled through private insurance, or not all of it, much of it. And medical schemes will start to consolidate. So this multiplicity of small schemes will consolidate into some bigger schemes, and they will cover a smaller portion of the population. That's the logic. So in order to do this, at the core of the reform, we have to improve the performance of the public sector. We all know that the public sector has many challenges, and unless the public sector is able to compete on an equal basis with the private sector, you're basically consigning people to a two-tier system, and that's what we want to undo. And how do we ensure the performance of the public sector is more effective, more efficient, accessible? Well, there are two main strategies. One is the National Core Standards, the Office of Standards Compliance, which basically inspects facilities, does an audit, issues reports, mandates performance improvement plans. So if your clinic failed on certain criteria, the next time around you have to produce a plan and show how you've improved and reached those standards. And then the ideal clinic is for the clinics, and you have the Office of Standard Compliance doing inspections in hospitals. We also want to draw in human resources currently in the private sector because we know it's very well distributed. So that would be, for instance, GP contracting, bringing them to provide primary care services. There's no opt-out of NHI contributions. everybody gets the benefits, so everybody has to contribute, and there's no tax subsidy. So by opt-out, we mean I can decide whether to join or not, but if there's no opt-out, it's by law I must join. And the tax subsidy, if you belong to a medical scheme, you can claim as a deduction what you pay to the medical scheme for income tax purposes. And that is actually quite a big sum of money, because there are a large number of public servants who are on medical schemes who are getting a tax rebate and a subsidy from government to be on those schemes. And that's a lot of money lost to the fiscus and a lot of money lost to the health department. So that will gradually be phased out, so that the tax subsidy is done away with, and the money that went into that will basically come back to the health department to fund the NHI. And the other main strategy is something which emerged actually prior to the NHI discussion, but it's about primary healthcare re-engineering. And that is strengthening the districts, creating primary healthcare teams at district level, district teams, which would include specialist support services. So you would have pediatricians, obstetricians, anaesthetists operating across the district to support basic surgical, pediatric, other care. You'd have the district hospital, the community health center, and a set of primary care healthcare providers
Oh my God.
in the districts. And you would also have a community-based outreach teams, which would consist of community health workers, environmental health officers, health promoters, etc. So that's basically the framework for strengthening primary health care. So what are the controversies and challenges in the NHI? And there's sort of 5, there are probably many more, but I'm just going to talk briefly about some of them. So in the way the NHI developed, there was a lot of talk around the relationship with the private sector. So the private sector is very powerful, as you saw in South Africa, economically and politically. And the NHI could potentially undermine a lot of the arrangements in the private sector, and particularly the hospital groups, which were very strong. So at one stage, there was a concern about the way the NHI had been captured, and I'll explain that. Second concern was around the way the NHI really started changing direction into supporting medical schemes rather than universal health coverage. The third problem was the lack of civil society participation. The fourth problem is looking at the NHI, there's a lack of focus on prevention and health promotion, and then the lack of attention to human resources. So this is an editorial actually in the Daily Maverick that People's Health Movement published, and it related to this idea that in the way the policy developed, there was a capture of the NHI policy by the private sector. And it stems from the white papers that were issued that introduced this idea of an advisory committee on the consolidation of financial arrangements. Very long title, but it was basically a committee that was set up to, in an interim way, to set up the funding arrangements. And what it proposed was that there would be 5 groups. There would be people in formal employment, there would be people in small-scale businesses, there'd be people in government employed, there'd be the informal sector, and then there'd be the unemployed, no employed. And each would have a different funding pool. And it's a fairly sort of abstruse technical argument, but what the problem is that once you start creating these different funding pools and benefit pools linked to those funding pools, you will never be able to merge them. So the experience in Latin America, for instance, when they set up health insurance was, they started with employed workers with the idea that eventually they'd include everyone else. And in fact, they never got to including everyone else, because once you have benefits, you're not going to give up your benefits to help somebody else come into the pool. So they've ended up with very complex and dysfunctional systems which are not universal access. And the fear was that this was the result of the private sector lobbying government, and that was the concern. This particular committee has disappeared from the final NHI bill, but it's not clear whether this thinking that one has to go incrementally building on medical schemes has gone away. The second challenge is really about the position of the medical schemes. So if we look at how the different policy papers have evolved, the 2011 Green Paper said that medical schemes would continue to exist alongside the NHI, and they would provide top-up services, but there'd be no tax, no subsidy. Okay. 2015, the White Paper introduces the idea of supplementary and complementary cover. So supplementary cover is cover that is a service that is not provided by the NHI, whereas complementary cover is a service that's provided by the NHI but is also provided by an insurance, a private insurance. And this allowed the creation of this fuzziness about who can do what and maybe the opting out. So there was some lack of clarity there. 2 years later, the White Paper consolidated a focus on medical schemes because it permitted the idea that you could subsidize medical schemes in the interim, whereas before, the whole idea was to move away from subsidy. So it seemed like over this period that instead of thinking about the NHI as about universal access, the way it was being thought about was, well, how do we take these medical schemes and fit them into a coherent pattern, which is the wrong way to go about thinking about it, because that's exactly what the World Health Organization says you shouldn't do, because it risks the idea that you entrench the inequalities that exist already in the system. So essentially, this was a movement away from a health system design to a health insurance design. Then the third issue was the way in which civil society was treated. In the first white paper, first of two white papers, there was a long list of different committees and different participants in the committees, and you can see from this listing, it was mainly government departments who were included, but there was quite a strong presence of private sector, private hospitals, medical schemes, actuarial society, and the Council for Medical Schemes, which is actually a statutory body, but it operates in that private arena. Whereas organized labor and civil society had one rep each on a particular committee. There was a big outcry. In fact, after that Daily Maverick op-ed, there was another updated government notice put out where the number of civil society members increased. But in fact, that particular committee that was created to advise government on the National Health Commission has actually fallen away in the bill, so it doesn't exist anymore. None of those committees are really mentioned. So it's still unclear the extent to which the public will participate in things like determining the benefits package in the NHI. Will it be decided in a room with experts, or will there be any public oversight or comment or opportunity to comment? It's unclear. And then, of course, we know that we have a huge burden of disease. It consumes a huge amount of resources. If we were to prevent that burden of disease, we would save a lot of money. Alcohol, violence, trauma, non-communicable disease, all of it. But what's quite disturbing about the NHI documents, the last white paper was an 88-page document, 434 paragraphs. There are mentions of prevention and preventive, and only 2 mentions of social determinants of health. But when prevention is mentioned, it really is about individual curative, individual care from a provider. There are reimbursement systems for providers, but they provide no explicit reward for prevention over cure. And prevention is spoken about as a vehicle for cost containment, but actually when it comes to costing the NHI, there's no prevention dividend. In other words, there's no net benefit financially calculated if you put money into prevention rather than cure. If you look at the models, it's just straight the amount of money we need to treat diabetes, hypertension, stroke, without any modeling of, well, if we put money into prevention, we could prevent that, and then we don't have to treat so much and spend so much. So it's basic sort of health economics, but it does reflect the preoccupation of the NHI with cure as opposed to prevention. And then when it comes to human resources, the bill really focuses on doctors and specialists, and doctors and specialists are important, but they're not the only thing that's needed. There's no real attention to nurse training. Community health workers are invisible in the NHI, but they're essential for those ward-based outreach teams. And again, it's a preoccupation about how to fund curative services. At the time, PHM commented that a human resources for health plan was urgently needed to ensure the strengthening of the public health sector. And in fact, in the last day, the Daily Maverick has actually published a link to the Department of Health most recent human resources plan. I'm not even sure if it's officially out, but they have sort of leaked it. And there is some discussion about community health workers in that plan finally, but it's taken decades for that to feature. In the initial white papers, there were various structures which were advisory to advise on human resources for health, but those structures really included mainly hospital-based clinicians and universities. And the argument was that since health professions education had simply reproduced the same maldistribution of healthcare professionals in South Africa, it's unlikely that they would be able to promote a universal health system based on universal access without any fundamental transformation. So what is being said in the private sector? These are just some comments. Quite a lot of suspicion about the NHI. One of the big IPOs, the head, said we need more pragmatism, less ideology. Government mistrust of the private sector is delaying the implementation of NHI. Time is running out for NHI, private healthcare CEOs warn. And then advisor to the minister then saying the private sector has a vital role to play. So a lot of interest, vested interest actually, but a lot of interest from the private sector, and it's unclear how this will play out. So just in closing, now we have COVID. So what does that mean for the NHI? Well, here's some of the headlines which basically ask the same question. Is South Africa's healthcare system prepared? Is it prepared for COVID, but is it prepared for the epidemic of injury, violence, diabetes, non-communicable disease, etc.? So our healthcare system was actually quite poorly prepared. Were we prepared for COVID? Well, we'll come back to that. South Africa's hospitals bracing for surge of virus patients. Okay. So actually all the existing flaws in our healthcare system are really exacerbated by COVID. But at the same time, policy solutions are possible and can outlive, not outline, outlive COVID. So this is a report in Bekisa about telemedicine. And some of you will know there was a brief faux pas by the Health Professions Council where they issued a guideline which basically was very restrictive of telemedicine and came under a lot of pressure, and they revised it. And in fact, telemedicine is now playing a very important role, which it could continue to play in the future, and particularly important for rural areas. Some colleagues have written about this, that COVID really is a wake-up call for UHC, because it really means that we have to have a national plan going forward. We've now crested our first wave in the Western Cape. We don't know how many more waves we will have, but we have to have a health system in response to this, so we have a robust, strong health system that can respond in future. And in fact, a number of editorials, particularly in Daily Maverick, have pointed out the need to use COVID as a way of rethinking our health system so we're more resilient, that there's greater emphasis on equity, that we're not locked into sort of a hospice-centric kind of healthcare system, and we should use this as a wake-up call. These are pictures. The one on the top left is the Kailicha facility that was set up for COVID, and the one on the bottom is the International Conference Center. And it is quite sobering that we set these up in a matter of weeks. So these are hospitals, not just tents, not just relocating people. These are hospitals fully equipped and functional. As it turned out, we didn't have to use all the capacity, and that was a function of things we're not entirely sure now. But basically, we were able to respond quite quickly in this situation. So in theory, we can effect very rapid changes to the health system if there is a political will, if there's imperative, if there's resources. So other colleagues in PHM have written about this. What would a post-COVID-19 health system look like? It would be people-centered, it would be responsive, it would embody the principles of primary healthcare, it would be efficient, it would not be corrupt, it would be all those things that we think we want to see. So the NHI will very much still be on the table after COVID, and we should be able to learn some lessons from that. So I'm just going to end off just telling a bit about People's Health Movement. It's a global network of civil society groups. It started primarily in South Asia, India, and other countries. It's very strong in that part of the world and also in Latin America. It's basically focused on health as a right. It has a charter for people's health. That's the web address if you want to explore further. It's active across 70 countries across the world. It runs what are called International People's Health Universities, which are basically short courses in the political economy of health. And it's kind of a school for health activists, global health activists, and the universities will be held in different centers each year, but COVID has now taught us that training in universities can happen virtually, so some of these might simply be transformed. It publishes Global Health Watch, which is a sort of alternative World Health Organization report, World Health Report. The World Health Report is brought out by WHO, and this is a regular publication by PHM, which is a more critical view about global health. It's held, I think, 4 People's Health Assemblies. It actually had one in Cape Town in 2012, I think, which is basically a meeting of different country circles who get together and strategize and reinvent themselves for global health activism. You can see the 2012 one was in Cape Town, and it was followed by National Health Assembly, and the health as a right is really central to that, that work. So there is a South Africa chapter, and that's the URL, and you can see I just took a picture of the website, which has a quite extensive section on the NHI. So that's it. I have finished, and I'll be very happy to take any questions.
Great, thank you so much, Prof. Landon. That was a really informative explanation. I know some of us get quite confused about what the NHI really means, so I think that was quite a succinct explanation. So I do have some questions here for you. So the first one was asked before your talk, so I don't know if it's been answered, but I'll say it anyway. So having outlined the basic outline of the NHI, what do you make of the concerns of doctors in private practice who feel they will not be able to dictate their own rates and will thus be underpaid?
So for the most part, doctors in private practice are subject to forces over which they have quite little control. So they are kind of at the whim of big providers, the hospitals and the insurance companies. And the private sector in that context is unsustainable. If you think about it, medical insurance members are paying more, they're frustrated, and basically, if the state can provide a decent service, people will choose to get a decent service from the state. So it's actually in the interests of private sector providers to have an arrangement which provides them with a good enough income, but which is sustainable in the long term. You know, it's quite understandable people will be fearful that the amount they paid will not be sufficient, but there's a sort of economy of scale which is also a kind of reassurance for providers. If you look at private sector providers during COVID, I mean, they were decimated because of the fact patients didn't go to private sector hospitals. Medical schemes have these big surpluses because we've still been paying into the medical schemes, but people aren't using private providers because of COVID. So I think there are actually some benefits to private providers. Of course, we know that private providers earn much more than in the public sector, so there is that tension. But as a policy, it's not going to remove people's options to use private sector providers. But if people get a good deal from an NHI, then the market will send them somewhere else.
Okay, great. Thank you so much. That definitely answered the question. So the next question is, what do you make of comparisons of the NHI to the UK's NHS, which has its failings?
Okay, so the National Health Service in the UK started off life as a fully publicly funded service. It wasn't insurance based. So insurance is on the idea that you pay into a fund and the fund will purchase for you, and it doesn't matter if it purchases from a private or public provider. The NHS was created after the Second World War as part of like the rebuilding of the British economy, and a lot of public money was invested in setting it up. And for years it ran as a fully publicly funded service, and it has done very well. It's achieved a great deal. It has problems now, but there are various reasons for that. And it has very high levels of ownership. So the British public, they kind of believe in the NHS because it's demonstrated its value. When Margaret Thatcher and subsequent Conservative governments tried to dismantle the NHS, they got a lot of resistance. And in fact, the average member of the public who might be a Conservative Party member does not want the NHS dismantled because it does or did deliver very good service. In the last few years, we've seen that kind of undone, partly because of this idea you have to have competition in healthcare. But healthcare and health is not like buying a fridge or choosing the best meal. It's not a commodity that you can, I'll go there or I'll go there. It's an essential service. And there are advantages to having a single publicly funded service because you can have coherence, you can have proper referral, you can have integration. So the difference here is that we have a very big private sector already. The UK doesn't have that. So given what we have to find a way to make sure that what we have contributes to a bigger good. And that's why the idea of an insurance comes out, although there are many people who argue that we should be talking about a national health system in South Africa, which could include a component of insurance. But that's essentially the difference. The NHS was fully publicly funded and delivered services publicly funded, whereas here the people who deliver the service might be public sector or a private GP or a private hospital, depending.
Okay, cool. Thank you. I like that you said health is not a commodity. I think that's something very important. So the other question we have is, it's very shocking to hear that South Africa pays more for private than America, the home of capitalism, as you said. Please elaborate on the exorbitant increase in private hospital and insurance and how detrimental their monopoly has been for our country.
Well, I'm not sure I can elaborate on that, but the question answers it all. If you have a monopoly, it's quite easy to set prices. And in fact, the market inquiry into private healthcare in South Africa really exposed that the private healthcare system is very unhealthy. It's not able to function in a way where there is real competition. There was comments about price setting. And it excludes people, basically, if you can't afford that kind of care, you have to rely on another service which is publicly provided. And we know classically where the public is starved of resources, the public sector, you can go buy it in the private sector, and that's the price of life. So in the private sector, as long as you can pay for it, you can get dialysis. And even if you don't really need it, you can pay for it and get it. If you don't really going to benefit. So you have this double standard in the public-private sector, and it's not morally defensible, and it's also economically and system-wise unsustainable. I'm not sure I've answered the question because I think the question is slightly rhetorical. It answers itself.
Yeah, I think that was a sufficient answer. But yeah, I do agree. So the next question we have is also related to the private sector. How do we lobby against the private sector? And how should the government and state sector try to get the private sector on board with the NHI?
So in fact, that article from the Daily Maverick actually touches on that quite a lot. So, and I'd recommend it quite strongly. So I think we need to understand that the people in the private sector are not the problem. They are working in a system, and it's the system that's the problem, because the system sets up this unsustainable contradiction. So if you can provide to private sector providers a way out where they can provide good quality care, have a decent quality of life, and operate in NHI, that is what we need to do. During COVID, various provinces negotiated with the private sector over providing services. And in fact, PHM's call was that in the same way that Spain and Ireland, they didn't nationalize the private sector. They basically commandeered the private sector for the duration of the epidemic. And they passed legislation which enabled them to say, well, all health facilities in the country at the time should be under one kind of management system, stewarded, however, in order that we can overcome this epidemic. And they did that. And they did that fairly successfully. In South Africa, what happened wasn't that. It was each province then set up a contract with private sector providers for very specific things. And the price over which they settled was basically a negotiation. It was a business contract. So, okay, we'll get X number of ICU days for COVID patients in the public sector at this price. But the problem was that if you set up a contract like that, then you risk the problem where people who are members of a medical aid will get preference because they're the insured patients, and the medical and the private hospital will then make the extra unused beds available to the public sector at a price. And so you're still getting that unequal two-tier system. And luckily, we never got to the point where people were dying because of lack of access to ICU beds, but that was the big worry. And had it happened, you would have had situations where, even though you'd negotiated access to private sector beds, other people eventually because they were wealthier, and someone who could have survived COVID would have died as a result. So that kind of inequality is not morally tenable, and a better system is where you have a unified, overarching pilot steering the system, and that is what the NHI is trying to do. Of course, the pilot has to be skilled, it has to be competent, and can't be corrupt, and that's the big worry. So yes.
Okay, great. Thank you. So we have one more question from Tanvir. She says, I'm struggling to understand what the role that the private sector plays. What is the strategy to combine private and public sector under the NHI bill? Will the government buy out public resources? What will the bargaining chip be to get privately owned companies to share their resources, including both capital and healthcare professionals? I know it's a long question, so if you look in the chat, if you want to look back at it, it's up.
So the logic is quite simple, actually. Basically, you will not be able to provide a service that is written into the NHI bill. So when the NHI Benefits Committee says these are the services covered by the NHI, no private sector provider will be able to provide that unless it's through the NHI. So there's an incentive to be part of the NHI for that reason. To be accredited in the NHI, you have to be approved by the Office of Standards Compliance. So basically, in a particular district, there might be 3 hospitals all available. One of them might be a public sector and 2 might be private sector. And the idea is someone in the NHI who has the NHI card could go to any of those 3 hospitals. Of course, there's an idea that you would go to the closest one where you live and be referred, and that sort of raises the questions of apartheid spatial planning, because if you live in a township, closest hospital will be in the township, and that's likely to be the hospital that's most overrun. But over time, that's meant to be reversed, so that there will be opportunity for people to get care across the platform. So the NHI is very clearly going to make it economic necessity for the private sector to be part of it, because the market outside of the NHI is going to get smaller and smaller, and it won't sustain the current system at all.
Great. Thank you so much. So we have one more question, and I'm just going to say that this is going to be our last question. We don't want to go a bit over time. So Francesca says there's something that she always struggles to understand with the NHI, is that if so much money is pooled, how will we avoid corruption when it is such a real issue in South Africa?
So that is a real issue. But remember, we didn't always have corrupt institutions. We had SARS, which was this pinnacle of probity and efficiency, and actually recovered more tax than was the case, during apartheid or prior to it. So there are examples where public sector institutions can be efficient and free of corruption, just as there are examples of private sector institutions which can be corrupt and inefficient. I used to think Telkom was a public sector institution when my phone went dead for 5 weeks and nobody told me about the progress on fixing it. And then I discovered actually Telkom was privatized about 2 years ago, amidst a great deal of fanfare that this was now a model of efficiency. But it's true, it's a risk, and that's why public oversight and transparency is so important for the NHI. So there's no simple answer to that, but you and I will just need to be very watchful and exercise our citizenship in calling it out if something goes wrong.
Great. I'm not sure, Francesca, if that answers your question. I think it did. But thank you so much, Prof. London, for presenting to us today. I'm sure we all definitely learned a lot.